Hi, I'm Greg Silverman from the NYU School of Medicine, and I'm here presenting my poster, number 585, on the Sunday session at the American College of Rheumatology 2016. We've been working on this project for a couple of years. Conceptually, we think this is very, very important. The question is, we're treating our patients, we're actually using primarily agents that block inflammatory pathways, and we're getting better at slowing the progression of radiographic changes. But what do we actually do to the underlying disease? I think it's been a little disappointing. Recent trials that have sought to stop TNF agents, and the longer you look at those patients after the TNF blockade has been discontinued, the more and more patients flare. How does that make sense? To me, it's sort of obvious because rheumatoid arthritis, at least the seropositive patients, it's an autoimmune disease, B-cell driven. These agents are not doing anything, at least that was our hypothesis, to the underlying autoimmunity. So we developed an assay that could actually quantitate one by one and count the frequency of memory B cells recirculating through the bloodstream that are specific for citrullinated proteins. And the question is, are they present in healthy people? We can't detect any of them. Are they present in rheumatoid arthritis patients? Only if there are detectable autoantibodies to citrullinated proteins, you know, the anti-CCP antibodies. And the question is, what is going on in these patients, and does therapy make a difference? So we did a cross-sectional study of adults being treated with methotrexate or with methotrexate with TNF blockade, and looked at patients at their disease activity using the standard DAS28 score and said, what is this doing with regard to the autoimmunity that's underlying the disease? And we found that there was no significant correlation with DAS28, and what I'm saying is even in clinical remission, there was a very similar and only modestly and slightly and not statistically reduced frequency of recirculating citrulline-specific B cells. And what does that really mean? We tested this in an assay that could look at dozens and dozens of specific citrullinated proteins and peptides. We compared it to a FDA-approved CCP3 that many of us use in the clinic, and we found, in fact, that the limited changes that occur with therapy for TNF blockade or methotrexate is paralleled by limited changes in the autoimmunity. In fact, there was a direct proportionality between your antibody levels and these bad lymphocytes. So put another way, I think that we're treating the disease but only disconnecting the autoimmunity from the inflammation. That's not going to really have long-term changes. Our patients are going to be dependent on these agents on, and we shouldn't be complacent and stop there. How are we going to cure this disease? How are we going to get to drug-free remission? I think we need metrics, and we need tests like this to be able to guide our efforts and find better regimens and better agents. So we're hoping that we're making a contribution.